where we have today two very big names from the Indian pediatric circuit. Uh, Dr. Vinyan, who's the speaker for today, and the session will be chaired by Dr. Praveen. Uh, can we have the CV of Praveen, sir, please? Sneha. So Praveen, sir, is the head of department. He's heading the Neonatology division at Department of Pediatrics at PGI, a well-known figure all across the country and internationally. He has special interests in ROP, hyperbilirubinemia, and QI. Uh, Sir has published numerous peer-reviewed papers and is practically involved in most of the guidelines and is directly or indirectly a teacher for many of us. Sir, I hand over the proceedings to you. And
Thank you, Vishal, and a very good evening to everyone. And it's really wonderful to join this interesting session being organized by the Association of Child Neurology. And I think today's topic is obviously of interest and relevance to both pediatricians and neonatologists in general, apart from the pediatric neurologists. And I think we could not have had a better speaker on this topic than Dr. Vinyan. So Dr. Vinyan KP, who is professor and head of Department of Pediatric Neurology at Amrita Institute of Medical Sciences, Kochi, again, a very well known name. And those of you who would have read the paper of the recent paper, reclassifying the neonatal seizures by ILAE, he is one of the co-authors and have been the member of the task force about neonatal seizures and several other groups of the ILAE. He also happens to be member of the Asian Epilepsy Academy, convener pediatric neurology subsection of Indian Academy of Neurology, and treasurer and member of several other associations. I think I would straight away pass on the stage to Dr. Vinyan to help us understand the recent changes, which seem to be pretty drastic, the rationale behind that, and how we can adapt them into our clinical practice. Over to you, Dr. Vinyan.
Thank you, sir. Thank you for that introduction. And it is my pleasure to be here on this day. And AOCN is a great platform. And at this point, Naveen and Vishal, they're doing a wonderful job as the conveners of this session. And without much further ado, I would share my screen and then start the proceedings. You can see the slides, no?
Yes, sir.
Okay. So start. Okay. See, the topic for today is what Vishal and Naveen has asked me to talk on was what Dr. Praveen was telling now, the recent definitions and reclassification of neonatal seizures and epilepsy. So what's the need of this, and then what's the current concepts behind this? Basically, this is coming from an epilepsy point of view, and it has to percolate to the pediatric and neonatology community in a big way. Otherwise, the whole thing will be a waste, and it's a lot of effort and man hours for coming out with these papers and the new classification scheme as a whole. So this will be the agenda for the next probably half an hour. So after that we can discuss this. But basically this will be the topic will be discussed on two papers. One is that the 2020 paper which came in 2021, epilepsia, the classification of the neonatal seizures by Ronit Pressler and group, where I was a member. And the next thing is the recent paper, 2022 paper, which on neonatal epileptic syndromes as a whole. There are 5 papers or 6 papers, and on that there is one paper on specifically a special report on neonatal and epilepsy, so the other way around, epileptic syndromes starting in neonatal period and infancy. So there I will be touching on those syndromes which are starting in the neonatal period, and then a few words about the current ongoing work regarding neonatal seizures in ILA, and then which way it can evolve. So the disclaimer for this talk specifically is, as we are all clinicians and we don't like discussion, concepts, and evolution, all those stuff, we want a utilitarian approach. So the pharmacological management is the key thing when we are managing neonatal seizures, but unfortunately, I'm not going to cover that in this talk because it's difficult to cover, and that itself will take 1 to 2 hours if you want to discuss this in detail. And as a dictum at this point, I'm not in the recent days, I'm not showing any of the patient videos on Zoom platform for the patient privacy point of view. So there are several, this is an assorted crowd, so I will start off with a very basic thing. The ILA definition at this point, the 2005 Fisher definition of epilepsy seizure, is a kind of electroclinical definition. That means an epileptic seizure is a clinical, a kind of conglomeration of signs and symptoms, which is very transient, what we call a paroxysmal event. And then it should be associated with abnormal or excessive synchronous neuronal activity in the brain. That means there should be a clinical symptom or sign, and that should be associated with the abnormal neuronal activity. If there is only clinical symptom when there is no associated electrographic event, then it is a kind of a confusion. So, but in a real practice, in a clinical practice, in all the ages across the life spectrum, we assume that there is an electrographic activity, because it is very difficult to do ictal EEG for each and every patient, and that's not possible, and that is not needed also. But when it comes to neonatal age, it becomes a little more difficult. Why it is difficult? We have been discussing this for a long time, because the standard definition, you all know, we all learned, and then this is a kind of the Volpe's definition, 1989 definition, is the standard in neonatal practice, which is primarily a clinical definition. Here it is defined as a paroxysmal alteration of neurological function. That means a behavior, motor, or autonomic function. But the problem with this kind of a definition is it includes both clinical, it includes clinical phenomena which may be epileptic or which may not be epileptic. Especially, it is a situation where you have a patient or a baby who is really encephalopathic in the ICU. You will have n number of moments, and then it is very difficult to differentiate which is actually a clinical or an electroclinical event, and which is or it is just some moment which is related to an abnormal brain function. That means it's classically the release phenomenon, release reflexes like the desynchronous, the decerebrate posturing, decorticate posturing, which are well known to be associated with severe encephalopathy. So that is the main issue when we are classifying, and then our clinical acumen is not enough to differentiate, because there are several landmark papers starting from Steve Malone's paper, which says that there is, even if you have years of experience in the NICU, you are not able to differentiate the same an event as epileptic or non-epileptic based on your clinical acumen. And there is a significant intrapersonal what you call variations also. So that means if you have been given a history like the patient is having such and such disease, you have a tendency to overcall or undercall depending on the underlying situation. So that is the main worry, and that means that we have to have better methodology, and the technology has evolved from 1989. Now we are in 2022, and such a definition with the new technology of the video EEGs and the continuous video EEG monitoring, it is not standing the test of time. That's the real purpose. That is a real issue when we were trying to do or work with neonatal seizure or babies with potential for neonatal seizures. Then the other problem with ILAE was, say, after some time, see why the ILAE was not trying to classify neonatal seizures, mainly because the real approach was that nobody was touching neonatal seizures because neonatal seizure was in a different area. So, and then it was considered as we can just take this whatever approach into neonatal practice. That is not also true. So we need a specific paradigm, specific protocols for neonatal seizures, because the overall milieu which the neonatology or the neonatologists are working are little different, because it's a, most of the time it's a kind of an ICU setting, and the standard epilepsy literature is for an outpatient practice. So the standard things will not take it. If you look at the ICU literature, it is much closer to the neonatology literature. So that is the real issue. So, and then there is an ACNS definition by the Tametusida, which is a recent one, where it is not specific for neonatal seizures, but that is on electrographic seizures and the duration, which clearly says that an abnormal EEG event, whenever you have an abnormal EEG event, which lasts for more than 10 seconds, you can take it as an electrographic seizures. And this is, even though there is no neonatal data, this has been taken to neonatology practice also when you are doing EEGs. And the other issue regarding neonatal seizures and epilepsies are the kind of data which we are getting. See, basically we know that the neonatal seizure literature is coming from the NICU. Why? Because it is very difficult to identify some movements as seizures in a healthy baby, and then most of the time they reach a specialist after the neonatal period. So even if the seizures started early, many times the classical neonatal epilepsies will come to a specialist only after the neonatal period. So it is too early to call something as a seizure, especially the family will not recognize, the pediatrician will not recognize. At multiple levels, there will be a problem. And there is another problem, that even if the patient or the family was told that this is a seizure, they will not accept that this is a seizure. So there are a lot of issues. But compared to that, in the NICU thing, when you have a baby who is actually sick and you are inside the ICU, so there is lot of literature. So most of the literature is in the NICU setting. And why that is important? Because whatever we are getting out of this, we will be specifically the prevalence of the etiologies will be highly skewed towards a kind of brain insults or anything which produces encephalopathies. So with this, so the main problem why you need a specific definition is the current terms or the current definition of Volpe doesn't hold the classical electroclinical concept. So that is the basis, but the earlier definitions are not fitting into neonatal practice also. So that's why this position paper by ILA task force has come, which is published in accepted in Epilepsia in 2020 December, and it was actually a fast track publication. It came in early 2021. So it is a kind of a work for almost 2 terms of task forces. So there was a first term which came out with, this came into the 2018, where again the lead author was Ronit Pressler, and the basic thing here was what they tried to put it was in a critical ill baby, you have to have a EEG confirmation to call something as an epileptic seizure, because the rationale for that is the plethora of papers which says that the clinical acumen is not enough, which we have discussed. I'm not going to the details. That itself, the seizure mimics in infancy, in neonates per se, is another topic. So you have the video EEG and amplitude integrated EEG as the key thing along with the clinical. So even before that, actually, you look at this, the clinical thing comes before after the EEG. So to make it clear, see, when you have an abnormal child or a child with a baby with an abnormal neurology, or you have a clinical suspicion of seizure outside the NICU setting, you have to first, according to this approach, you have to first have an EEG and then try to say that it is an epileptic or non-epileptic. And then try to classify that. When you have an EEG correlate, then only you call this as a seizure per se, or an epileptic neonatal seizure. The others are also the so-called all the others which came in that old Mizrahi and Volpe literature is all, if there is no EEG correlate, it comes as a non-epileptic event or a non-seizure episode. And when you have a EEG correlate, you call it as an electroclinical seizure. And if you don't have a clinical sign, it will come as an electrographic only seizure. So the thing is, there is a kind of what you call a paradigm shift here, because usually we go clinically first and then go to the EEG, and then you reach a conclusion. That means you have a clinical diagnosis, then you have the investigations, and then you reach a conclusion. But here, what the task force did was they put the electrography before the clinical thing, because the difficulties of the clinical diagnosis of seizures in the newborn. So what was the criticism? The main criticism was, as clinicians always we feel like we are not able to accept our limitations of our clinical what do you call that, the difficulties of clinical diagnosis, or what you call the limitations of our clinical diagnosis. As physicians, we are very possessive of clinical medicine. So that is one thing. But the major issue when it comes like this from an ILAE, like an international body with such a pan or global presence, is that the video EEG, amplitude integrated EEG, is not available in all the settings. So what did they do? This is becoming a standard. So that became a major issue, because according to the current ILAE SOP, all this task force work should go to the public domain first in the website, and then there should be the comments will be asked, and then based on the comments, there will be further work. So this became a major issue, and then they expanded the task force, and at that point we all got into this neonatal task force, because that's a major issue. So for a applicability across multiple settings. So that was the real issue. So this has been accepted, and then the some kind of a kind of what you call a bypass strategy was first came from this paper. So this is again, I was part of this paper, Professor Anuja was there, and this is coming from a pure what do you call, a combination of pediatric and neonatologists, then obstetricians, epidemiologists. This is basically to look at the outcomes of immunization in pregnancy, and the outcome measures were defined for the Global Alliance on Immunization, and this came in vaccine. So for that, the neonatal seizures were approached in 3 levels, and those 3 levels were, the first level is as what was discussed in the original proposal. You have to have an electrographic event, and then you can have a paroxysmal alteration. So you have to have a continuous EEG to clearly call it as a level 1 seizure and an electroclinical phenomena. And if you have only electrographic thing, no clinical, you call it as an electrographic only event. But you have some other levels. You don't have to be sure that it's always level 1. You can have level 2. Level 2A is when you have an amplitude integrated EEG. It's the same approach. You have an electrographic seizures in the amplitude integrated EEG, and then you have a clinical thing or an electrographic thing. So electrographic only thing. And the level 2B was based on some data which clearly showed that if you have a focal seizure, if especially a focal clonic seizure or a focal tonic seizure, not a generalized tonic seizure. So if you have a very clear focal clonic seizure, usually it is epileptic. So if you have that, the chances of an epileptic event is very high. So even if you don't have an ictal continuous EEG or amplitude integrated EEG, you can call it as a level 2 diagnostic certainty and level 2B. was attached to this. And when you don't have amplitude integrated EEG or continuous EEG, but you have an experienced medical personnel. It can be anybody. It can be a nurse staff in the NICU. It can be a neonatologist or a fellow who clearly says that it might be a seizure. Then it is, you have to accept that it is a seizure and then treat it. But understand that for this purpose or for a scientific point of view, you are at the level 3 of diagnosis. That is the lowest level according to this paper. But in the final paper, which came in epilepsia, there is a 4th level was added. That is when you have an observed, there is only a history. Nobody has seen it. Okay. Nobody has seen it and nobody has observed it. Then it became, that is the classical practice. If you look at the pediatric practice of seizures, many times nobody has seen it. And it's only a history. And there is no video and no physician has seen it. But still we take it as a seizure. So, but in the neonatal period, so probably in the years to come, there is a chance that this kind of an approach will come to other ages also, because there is a problem when you have a abnormal or some paroxysmal event where you call it as a seizure, start treatment. You have to understand that you have to have you have only an insufficient evidence to call clearly any paroxysmal event as a seizure. Okay, so with this, the definitions and the concepts and how it evolved in that paper, I am going to the second part of this, the neonatal epilepsies and what is the concept behind the neonatal epilepsy. See, epilepsy for a beginner, it is always better to start with the basics. The difference between a seizure and epilepsy is seizure is a one-time event. Epilepsy, we are looking at a continuous process. That means there is a chronic process, that is an enduring predisposition to generate epileptic seizures. That means the brain has been tuned to develop further and further seizures without any stimuli. It can be due to an insult to the brain, or it can be due to a genetic abnormality, or it can be due to some other abnormality, but usually it is either structural or a genetic origin. So this is the concept of epileptogenesis. Again, for the beginners, I will say that you have to have an initial trigger, some kind of an insult. So it can start in utero, or at the time of, if it is a genetic abnormality, it starts very early in life, in the prenatal period, and the baby may present with a seizure in the neonatal period, or it is a kind of an insult an acquired insult to the fetus or a fetal brain, and the seizure develops in the neonatal period. So that means you have to have some time, and this time depends on so many other factors. It is depend on the time of the insult, or sorry, the type of the insult, the severity of the insult, and the genetic predisposition of that individual. Lot of things. The latent period actually varies from weeks to months to years. See, this is from a standard adult literature. That's why they put it as few months to years. But if you look at our data, so it can be days to weeks to months. So in the pediatric period, or years also. Okay, so that means in the neonatal period, if you look at it, you know the causes of neonatal seizures. So the approach to epilepsy, according to the current 2017 paper, the Ingrid Schiffer paper, is you don't have to go through all these things by seizure types to epilepsies or to syndromes and epilepsy with etiology. If you see a seizure type and you know the etiology, you can actually jump into the etiology. You don't have to have all these things here. So the point I am trying to make here is, if you look at the neonatal seizures etiology, most of the time, if it is from the NICU, the data is coming from the NICU, whether it is high income countries or middle and low income countries, there are a lot of papers. You know that most of the papers which will say that it will be some kind of an encephalopathy. Either it is an acute encephalopathy of the hypoxic ischemic injury, or it is infections if it is in the LMIC area, or in a part of it may be due to some metabolic events, and So if you look at it, almost all of them are due to some kind of an acute insult, except that the cerebral malformations and the inborn errors of metabolism and the genetic epilepsies. So that means most of this are going, as I told you, this is another way of putting it from that paper on neonatal seizures, the Ronit Bressler paper, which clearly says that majority is acute symptomatic, or the other way around is, and related to an acute insult. And this is what we call the acute symptomatic seizure. So the most of the neonatal seizures from the epilepsy point of view or the epileptology point of view are acute symptomatic. And what is an acute symptomatic seizure? See, otherwise called a provoked seizure. This is anybody who wants to do some work on epilepsy. This is a very old paper, 1993, from the then Commission on Epidemiology and Prognosis, which defined many types, the what you call a kind of a epidemiological definitions when we want to do work on research work on different types of seizures and epilepsies. So according to that, it is conceptually it is defined as any seizure occurring in close temporal association to an acute systemic, metabolic, or a toxic insult. That is the systemic thing, or in association with an acute CNS insult, which is it can be due to, it can be anything. It can be a trauma, it can be a stroke, it can be a infection, it can be a intracerebral hemorrhage, or it can be an HIE, or it can be anything. So two things here, there are two entities in an acute symptomatic seizure. Either it is an acute CNS insult, which is specific to CNS, or acute to the brain, or it can be an acute systemic process like a metabolic dyselectrolytemia, or something of that, or a hypoglycemia, or any of those things. So if it is an acute systemic process or a uremia, or then it should be the proximity, the definition goes like this. If it is an acute systemic process, it is only to 24 to 48 hours, the proximity. But if it is a CNS insult, it is a little prolonged, it is up to 7 days. So in a stroke or an HIE, anything which happens, any seizures which happens in the first 7 days is considered as an acute symptomatic seizure. So, and then the other thing is it should have a biological plausibility. That means that causation effect, the dose effect, all these things should be there. And most of the time, when you have an identified etiology, except a chronic thing, it becomes an acute symptomatic seizure. So an acute etiology, systemic or CNS insult. So if you look at the neonatal seizure etiology, most of these things are acute symptomatic seizures. So that is a very important thing. Why? Because if you have a neonatal seizure, usually our approach in epilepsy is, as I told you, to go by the focal, generalized focal, and then go to the epilepsy syndromes. So, and identify the epilepsy, and then see whether epilepsy has got an etiology or not. Okay, but why we are going like that? Because most of the time the epilepsy is in a across life spectrum. We don't have a clear etiology, and you have multifactorial etiology. So the only way to define those is based on the symptomatology. But if you have an etiology specifically, and if you have an acute insult and there is no chronic tendency, why you want to go into this kind of a focal, generalized, all this stuff, and try to say that it's a myoclonic or tonic or any of the things? That doesn't make any sense actually. If you have a hypoglycemia, whether it's the child has got a myoclonic seizure or a GTCS, it doesn't make much difference. You have to treat that etiology, and then that's it. So the issue here was there are certain classification with the 1973 OLP classification, which has been later reclassified by OLP itself, and then the other standard classification was the 1987 Mizrahi-Callaway classification. Both these things are specific for neonates. Others, the ILA classification schemes were actually, the neonatal period was not considered in specifically, but they just told that it can be extended to the neonatal period also. So the real issue here is, even though Volpe and Mizrahi-Callaway both to some extent, even though they try to take some of this ILA literature and then went into describe that based on the tonic, clonic, and all these things. the purpose of this was not clear. Why you want to define this? So the real issue when this paper was envisaged was this issue, whether you have to go by the standard epilepsy literature or you don't have to do in neonatal seizures, because the 99% according to current literature, 98%. So the more and more we take this neonatal seizure studies outside the NICU, you will get more and more the non-encephalopathic babies. Probably the incidence of the epilepsies increase. Probably there is a need, but otherwise in the NICU, is there a need? That is the real question. So the real approach was at that point, the initial 2018 proposal tried to classify it as not as a focal generalized or anything. They just classified it as motor or non-motor and electrographic. Okay. So, but then it is not going by the standard epileptology literature. So there are conventional epileptologists who are saying that this doesn't make anything because there is no scientific thing here. Because the scientific term, the standard terminology at this point is focal versus generalized. And so this was discussed at length and again and again. So the second task force was discussing it again. So the initial proposal to call this as the motor types are classified as automatisms, clonic, epileptic spasm, myoclonic, and they've added one new thing, that is the sequential seizure. And then the non-motor thing was autonomic behavior arrest. And another issue which was discussed at length was the most of the time in epilepsy literature, the first manifestation was given the most importance, because especially in a focal seizure, especially from a epilepsy surgery milieu, you have to know from where it's arising. So that is the most important thing. But in a neonate, it is otherwise also it is very difficult to classify. And the onset anyway, epilepsy surgery is not a major thing in the neonatology practice. So here they went into the standard epilepsy thing, the old epilepsy literature, and said that the predominant manifestation, you take the predominant manifestation in that seizure and classify it. So if the predominant manifestation is a clonic thing, you call it as a clonic thing. If the predominant manifestation is a myoclonic thing, call it as a myoclonic thing. And then they added a sequential seizure, because sequential seizure is a seizure where you are not able to, a prolonged seizure, which you are not able to differentiate whether you have a predominant manifestation. So this is a change from the standard literature, and that is not there in the other ages across the life spectrum, only specific to neonatal period. So this sequential seizure is an issue because it has been this terminology came from the genetic encephalopathies, especially the XBP1, KCNQ2, and other literature, where they call this as a sequential seizure because there is no specific predominant manifestation of a clinical seizure. So you can go into these details. It's there in the paper. So nothing great here. The main thing here is just to take the original literature from the glossary of the epilepsy and then put it into neonatal milieu. That's what they did, but there is no clear data to say that this is useful. But they tried. So before going to the further thing, you know that this kind of an approach. See, basically utilitarian approach is important. Approach etiology is the standard literature. Anybody who has gone through the neonatology, you know this. So when you have a clinical approach based on the age, you can say that what is possible or probable as an etiology. That is always good. So that way they try to look at the different types of seizures, but the main criticism here is this is going to be a part of a new paper, which is actually in review in epileptic disorders. They looked at different seizures and tried to correlate with the etiologies. And one thing is very clearly emerged, that preterm child or preterm babies have got mostly electrographic seizures. And another thing is this myoclonic to metabolic thing. That is also, there is a trend. But again, the main criticism against this approach was the numbers were very less and it is only a trend. We need better data. And another thing is this focal clonic seizures, or the clonic seizures associated with strokes and the vascular injuries here. Okay, so and the sequential seizures were more in genetic disorders. Okay, so finally, there are a lot of a lot of work, and whenever there is some work is being done, there will be a lot of questions. That is science. So the final paper, again, even though there is a lot of questions whether the sequential seizure is actually going to help or going to have confusion in the, especially when it goes out of the epilepsy or epileptology group, how they will, especially people who are not trained for taking that predominant manifestation, everything can be called as a sequential seizure, because many seizures, if you look at it, can have an evolution of the pattern, the semiology. Okay, so finally the paper came out with these three things: the approach to the seizure and approach to epilepsy. Okay, out of that, I have put that epilepsies in blue. The most of the things are majority hypoxic, structural, vascular, infectious, or acute symptomatic seizures, but metabolic, genetic, and brain malformation. The structural can be either vascular event, the acute stroke-like thing, or it can be a brain malformation, a diffuse brain malformation, or a focal focal brain malformation. So these are mostly epilepsies. So the last part of my talk, the neonatal epilepsies and the new recent paper, which has defined the neonatal epilepsy syndromes. So if you look at that, what is the commonest epilepsies which comes in the neonatal period? One of the commonest epilepsy is a structural malformation like this. This child came to us on day 15 of life. The seizures were from day 10. It was clearly a right focal seizure. And yes, the child had a focal cortical dysplasia, large cortical dysplasia. So when you have a multilobar cortical dysplasia or a hemimegalencephaly, so this child ended with epilepsy surgery. So the early MRI. So one clue here is one early MRI. You can see that this is the first MRI, and this is another child who has got a large cortical dysplasia on this side, which the MRI was done at 6 months of age. It was not very clear. So when you have a focal seizure, but clearly on one side all the time, it is better to do an imaging in the neonatal period itself. That's a practice tip, which will help us in the long term also, because it's after some time when the myelination proceeds, it becomes a little more difficult to identify the abnormality, the extent of focal cortical dysplasia compared to the neonatal period. And you can have large lesions like hemimegalencephaly, a highly epileptogenic lesion, or you can have a stage over, but stage over presenting with multiple seizures in the neonatal period is a little rare, but you need better data. So you see the kind of the purpose of all these things to have further focused research to know how the types of seizures are evolving in the neonatal period or in the early infancy. So again, a kind of a breakup of neonatal epilepsies. You can have electroclinical syndromes, structural malformations, chromosomal single gene defects, or dysmorphic syndromes. But how many of them are actually starting in the neonatal period? So most of the time we call it as an early onset epileptic encephalopathy or early onset epilepsies, because the pickup of those seizures in the neonatal period is relatively less, because these children are outside the NICU area. So this is the recent paper. All of you might have seen this, especially pediatric neurologists. All the pediatric neurologists might have seen this. So this is the 2022 paper, and a series of papers on different epilepsy syndromes across the life cycle, and one paper on specifically on neonates and infants. Out of that, they have classified this into three types: the self-limited epilepsies, developmental epileptic encephalopathies, and then they have added a specific group in this age group, which is the etiology-specific syndromes, or now the current task force takes it as an etiology-driven syndromes. So the self-limited epilepsies is our old benign epilepsy, the benign familial and non-familial epilepsies. There is not much difference between these two, and the outcome is good. So you can, so the main thing they looked at is all these syndromes are classified as mandatory things, alerts and exclusionary. So you can go to the paper and look at this, and there's a very wonderful approach, I will say, by the alien virals group. And the main thing here is the outcome. The type of seizure can be anything, the EEG can be anything, and the outcome is the most important thing. And then some of the things are relatively exclusionary, like if you have an epileptic spasm in the neonatal period, if you have a myoclonic seizure or a tonic-clonic or a tonic seizure, you have to be careful. So I'm not going to the details here. And then it has got a genetic component, you know, that the potassium channel, KCNQ2, KCNQ3. And here there is a neonatal infantile epilepsy. The only difference is it starts in the neonatal period and then goes on into the infantile period. Classical genetic genetic variation is the CN2A. And mostly they are focal tonic seizures, and then again myoclonic seizures and spasms are exclusions. Sometimes you can get sequential seizures. Then the other group in the neonatal period is this DEE, or the developmental epileptic encephalopathy of early infancy, or the EIDEE, which is the only one which starts in the neonatal period. EMIM, the migrating focal seizures usually starts a little later, and the classical type. So again, the epileptic encephalopathy concept has evolved. You see that in the neonatal period we had only the Ohtahara syndrome or the Aicardi syndrome, and now the concept is developmental epileptic encephalopathy, because the epilepsy alone is not the issue. You have the cognitive and behavior impairment, movement disorders, all these things, and epilepsy can contribute to the whole cognitive issues. So the main difference in the recent paper is they have clubbed the Ohtahara and Aicardi syndromes, the myoclonic epileptic encephalopathy and early Ohtahara syndrome of early infantile epileptic encephalopathy. All these things, these two have been clubbed as one syndrome. And the main thing here is you can have abnormal posture tone movement, abnormal neurological examination findings, profound developmental impairment, and abnormal EEG, especially the burst suppression pattern. And you have multiple causes, because this is a syndrome, you can have multiple causes. So it can be a structural abnormality, it can be a metabolic abnormality, it can be a genetic abnormality. So usually in 80% of cases there should be an identifiable abnormality here. So this is the EEG feature. So there is a type of seizure is mostly spasms and myoclonic seizures, and the EEG is burst attenuation or a burst suppression pattern. So this is just to show that the old literature of the Ohtahara and early myoclonic encephalopathy now, according to this concept, has been clubbed together as one syndrome. So again, the mandatory thing is tonic or myoclonic seizures, burst suppression pattern with EEG showing burst suppression pattern with diffuse slowing, age onset, birth to 3 months. Usually it can start in the neonatal period, but it can start a little late also. So there are some genetic abnormalities, and the list is growing here. So the type of seizures and the genetic abnormalities, you can know that the sequential seizures are usually seen in genetic abnormalities. Tonic seizures are the standard. Myoclonic seizures are relatively rare in pure genetic epilepsies, but mostly in the metabolic disorders. And there are some, like there are new literature coming up, like UBA5 can be associated with myoclonic seizures. So this list is going to grow, and we might get better patterns in the years to come. So this last part of the etiology specific syndromes, I am also not very clear. So the concept is evolving here, and there is a new task force, etiology driven syndromes. I have been also invited to be a part of this. So I'm not very sure how it will evolve, because you can see that Dravet syndrome, which is a clear genetic epilepsy, it is in the developmental epileptic encephalopathies according to this concept. So this needs some work. So the other genetic abnormalities, basically the thing here is, the concept is, you have an abnormal gene, and then you have a clear clinically differentiable syndrome with a clear EEG, or a series of seizures, clear EEG, and a classical clinical pattern or an outcome which can be defined. You can call it as an etiology specific syndrome or etiology driven syndrome. So this is a little different from etiologically driven or etiologically specific epilepsies. Like if you take this infections like SSP or NCC, they are actually etiology specific epilepsies. But in NCC, it depends on the area of NCC. The type of seizures can be different, and you can so there is a lot of confusion here. It is not clear. The symptoms are the concepts are evolving. Probably the next task force will look at that in detail. But at this point, you have to take it as this is an arbitrary classification. There is no clear data here. This is just a kind of a guideline for future research. So the last part of this, the genetic epilepsy, the metabolic epilepsies, this starts in the neonatal period. So this is a specific syndrome. This is etiology specific syndrome. So probably this group will come into a etiology specific group, and there are specific treatments also. So as a group, this is a kind of what you call a standalone group, where you have an etiology, you have some clinical features, and you have a management, and you have an outcome if you are picking up it properly. And the last slide, what is an ongoing work at this point? Neonatal seizures. There is an evidence-based management guideline is coming up. It is nearing publication. It's nearing submission at this point, but it is a lot of work at this point because it is almost 6-7 years have been gone into this evidence-based guideline. But I'm not very sure, because new things are coming up, especially like the new management paper which came on early withdrawal of AEDs in the neonatal ICU. Those things have not been included in the original paper, so probably it might need a revision. So it is expected that in 2023 at least this paper will be out. And as I told you, the etiology driven syndromes, especially in the newborn period, the genetic epilepsies, there can be specific papers in the near future. That almost completes my agenda for the day. Thank you.
Thank you very much, Dr. Vinyan. I think this has been a really wonderful presentation. You have really, brought out why the good old clinical classification of Volpe, which all of us have grown up with, have been kind of drastically changed. And you have given us several kind of physiological reasons, biological reasons why it should change. But as you rightly hinted, one is not sure how will it be kind of applied in real clinical practice. Because even though Mizrahi and other people came out with this idea that you have a lot of electrographic seizures which are undetected clinically and which are potentially harmful, we haven't seen NICUs having a lot of EEG machines even after more than 20 years or so. So currently what I see the challenge, as you said, is, so you said we need a video EEG. So first of all, people don't have the video recordings in most units. Now, even if we do have video recordings, then we saw the study that, there's no inter-observer agreement. So maybe we need something like machine learning and artificial intelligence to really interpret those movements. And then if we have EEG, then again, who interprets that? I mean, we need a trained, not only a simple pediatric neurologist, but maybe a pediatric neurologist with a neonatal experience. So it is obviously challenging, and that how does one really apply in real life? But I think it does lay good foundations for a lot of research in coming years, trying to understand how this can be applied. And, and it also gives us good ideas about, because we see a lot of clinical trials of different anti-seizure medication being conducted. So, what outcome to target, that itself has not been clear, then obviously those studies would be useless. So it does give us some ideas, how we can target that. And I think ultimately for any neonatal intervention, the kind of final outcome everybody is looking for is the neurodevelopmental outcome in the long run. If something improves it or it doesn't improve, that is the. So I think it's next few years we are going to have obviously a lot of research based on this. And I'm pretty sure a lot of audience who are in real practice would be wondering how do we apply it, and how do we use the EEG or the video, how do we interpret, and not only in the tertiary care NICU. Once we go down to the district level, then how do we actually handle all this? So with these few words, I would hand over to Dr. Vishal to list out the questions which would be there in the chat box, and I'm sure Dr. Vinyan would try to address it as he has been part of the group who developed this classification. Over to you, Vishal.
Thank you, sir. And it was, as always, wonderful hearing you, sir. I'll start with a question of my own, sir. So we have been brought up with a terminology which is very peculiar in neonatal seizures. We call it subtle seizures. So where does that subtle seizure fit in this entire framework which has been proposed by ILA? Because a lot of lip smacking and other things, vague movements, would end up getting listed as subtle seizures. So with the current ILA classification, where would we fit those subtle seizures?
See, the subtle seizures goes into two things. One is that motor movements, which is automatisms, something like what we call the smacking movements, eye up rolling, and then chewing movements. So mostly it goes into motor automatisms. And then you have another group where there is a change in the heart rate or a respiratory pattern, which goes into the autonomic group actually. So, and then see, it's a very vague term, no? You know that all of us worked in the neonatal period, neonatal ICU. You know that it depends on what you think at that point. It can be a motor arrest also, and then you say that it's a seizure. So finally, the so-called subtle seizure is actually some of them are clearly non-epileptic, but some of them can be epileptic, especially this motor automatisms can be epileptic, and arrest can be epileptic. So there are several studies which showed that it can be associated with epilepsy, epileptic discharges, continuous EEG recording, or it may not be associated also. Especially, it depends on the encephalopathy point. If it is a severely encephalopathic child, then the chances of those being a seizure is a little high, and it depends on a lot of things. So at this point, they are asking us to call it as more of describe it properly like a semiology, and then use it, you see whether you have got any EEG correlate or not.
Okay, another question, sir. So in neonatal seizures, there's a shift from the onset word which we use for children and in adult epilepsies, that whether it was a focal onset or a generalized onset seizure, to a predominant type of seizure. So could you please elaborate on that?
See, the concept here is, see, what is a, that goes into a hardcore epileptology there. See, what is a generalized seizure? See, generalized seizure is a major group feels like it's a misnomer. There is nothing called a pure generalized seizure. It starts somewhere else, somewhere in the brain, and then it goes on. So the classical generalized seizure, which we call is an absent seizure. So absent seizure is the classical thalamocortical kind of an discharge, which is a hypersynchronous discharge, which goes all over the brain, and it starts inside subcortically, or it is the major driven pacemaker, even though we cannot say that it started there, but the pacemaker is in that the thalamocortical system. So that kind of a seizure is not there in the neonate. So that is the first thing which was discussed. So there is nothing like the absent seizure in the newborn period. Okay. So if you accept that, then then it becomes everything is a focal seizure. Okay. So everything is a focal seizure in that. So if you look at the last paper, they say everything is a focal. So then in that focal, so the real question is whether we will be able to identify the onset or not. So is there a need to identify the onset? So that is the first question. Is I discussed that whether there is a need to actually classify the seizures per se. That itself is a question in the NICU setting. So in that sense, if you why you want to classify that? Classifying is primary. Sorry, then looking at the onset is one thing is to identify the function in epileptology. If it is, we know that it is coming from the cingulate, then you get a specific pattern, then you know that cingulate is working like that. So epileptology is helping us to learn neurobiology of that circuit. Okay, that is one thing. That is a pure science of that. The other thing is the utilitarian kind of an approach. Utilitarian kind of an approach comes from the surgical epileptology thing, where you know that if you think, look back, what we call the reverse phenomena. You have a specific semiology. You say that it is coming from certain parts of the brain. Okay. So that means you are trying to say that this, when you have an occipital or a visual complex visual hallucination, this is coming from probably from the visual association areas. Okay. So that way we are actually helping in the localization thing. Okay. But in the neonatology area, whether there is a need for that at this point, and we have enough data for that. Both things are not there, because even there is a clear literature at this point which clearly says that, or if you have seen infantile EEGs, or not only neonatal period, if you take a 6-month or a 3-month-old child with a clear focal cortical dysplasia on one side, you can get ipsilateral clonic jerky because of the myelination difference, and the myelination is not proper. So that kind of the adult literature taking the same thing to infancy doesn't work there, probably. So that is why because of these two reasons, and then the difficulty that everybody, the purpose of this classification is to take it up across the neurology, epileptology spectrum. The committee felt like predominant manifestation is okay. Okay. So, but the epilepsy point of view, predominant manifestation doesn't help anybody. Okay. So predominant manifestation just says that at that point, there will be a lot of intra-observer, inter-observer variability if you look at the predominant thing, especially in a mild thing. If it is a very prominent thing like a focal clonic seizure, nobody will miss it. That's why the focal clonic seizure is the clear seizure which can be identified in the newborn period and with a clear localization. Okay. Other things, it is a really tricky thing. So at this point, a spasm versus a myoclonus, a generalized tonic seizure versus a generalized, focal clonic seizure, this helps in a way. Probably this is the committee at that point is feeling like what I felt was the committee's discussion was, they are giving just a kind of a framework to work on, as Professor Praveen Kumar told. See, this is a kind of a framework. This is not a kind of an hard and fast thing. Probably with years to come, if we have more and more video data coming from the newborn period and early infancy, we might get better data to classify and have a clear kind of a semiological approach as in the other ages.
Absolutely. So it's a work in progress, and we have just made a head start as of now. So two questions interrelated. So first is, can you clarify a bit more about sequential seizure? And second, related to the same thing, is if there is a brief rhythmic discharge, can it be classified as a sequential type?
See, sequential seizure is a specific type of seizure. If you have seen that seizure, you will not miss it. See, it is a prolonged event. Primarily, it is a prolonged event where the seizure evolves over time, and it is not stopping like the standard seizure, especially in the neonates. You can see that, especially in many genetic epilepsies, KCNQ2, XE, XBP1. There are some seizures where you can get this kind of prolonged events where it starts with the focal component, then it goes on to tonic, and then the child jerks in between and then can have a spasm. So it goes on like that. That is the classical sequential seizure. It's not for a short event. Okay, so the again, this is it can be questionable at that point, because if you are not having a clear idea what is a sequential seizure, there is a tendency to call every movement, because the evolution can be there. See, any seizure, if you look at it, what we call the seizure evolution in other ages, other age groups, if you look at that, if you get a focal clonic movement first, and then it goes on to a generalized clonic movement, and then goes into a tonic posturing. It is a natural evolution. Okay, that we will not call it as a sequential seizure. The sequential seizure is a situation where you can have a prolonged event. Little difficult to define it, but if you have seen a seizure clearly of a KCNQ2 developmental epileptic encephalopathy, you will understand that.
Right, so there are two questions which are slightly unrelated to the talk, but since we have two experts, we can take them on. What is the best time for doing MRI in HIE? We have both the experts, both of them can take that on. So best time for doing MRI in hypoxic ischemic encephalopathy.
You can start.
Praveen sir, we can start.
I think it all depends on the purpose for which you want to do. So typically people would like to do it for prognostication. And so generally for that purpose, toward the end of first week would be a possibly good time. On the other hand, sometimes, because somehow HI seems to be also sometimes a dumping diagnosis, that everything is labeled as HIE without fulfilling all the criteria for labeling it. So sometimes I think if you have a doubt, there's no setting for asphyxia and maybe then encephalopathic is the kind of so sometimes stroke can be something which is missed. So for which you may want to do earlier a different type of MRI, but typically for HI we would do it toward the end of first week.
Yeah, nothing more to add here. Sir has clearly told it. The purpose. It depends on the purpose, and the purpose is prognostication. You have some data on that which says that 1 week or after 1 week is better. But if you look at, especially if it's a diagnostic point of view, it is better you do early, and the earlier you do, and then there is a technical issues also. No, a sick baby shifting to the MRI room, so it is going to be difficult. But as time evolves, I was talking to my radiology colleagues now. There is a chance that there is a tendency to move into the permanent magnets again, and you can get small magnets which is coming to the bedside. Probably if you get that, every other patient, every other baby can be like a neurosonogram, we can do an MRI. So it depends on the risk benefit at the end of the day. Yeah. So what are we going to gain out of this investigation?
Yeah, I mean, portable MRI systems are available now, obviously very expensive and difficult to get.
Okay, there's another one which is like that, not directly related to the talk today. Neonatal hypoglycemia with MRI showing diffusion changes. What would be the recommended duration of initial treatment? I think what they mean is that there's a child with symptomatic neonatal hypoglycemia goes into neonatal seizures with MRI showing effects of hypoglycemia. What would be the recommended duration of treatment, initial treatment? Praveen sir, we can start with you, sir.
Yeah, I mean, so typically, like, we have not been deciding the duration based on MRI. And in general, the goal is to kind of get rid of anti-seizure medication as early as possible. And several studies are there where you try to stop it even prior to discharge or at the end of first week, provided baby is neurologically normal and not seizing anymore. Of course, now this is with a caveat in view of Dr. Vinyan's talk that this is all without any kind of EEG monitoring, it's all clinical. So, however, if baby is obviously neurologically abnormal, then we tend to continue the anticonvulsant medication and then see in the follow-up and try to again stop it as early as possible. But I suppose you had simple hypoglycemia, baby seizures, neurologically normal, and obviously we don't do MRI for them. One would actually possibly not even give anticonvulsant. In case they have been started, one would take it off quickly. So maybe Dr. Binyan can add to that.
Yeah, see, it depends. We are going to see more and more of, if you do an MRI in a hypoglycemia, there is a real chance that we are seeing more and more of diffusion restriction in that area. Because it is expected, because we have a long-term outcome of neonatal hypoglycemic brain injury with gliosis in that area. But see, identifying that MRI from the standard MRI, and that increased diffusivity, which we discuss in many cases, it is a little tricky thing. But anyway, see, the issue here is, as Dr. Praveen Kumar was telling very clearly, he has clearly put it across. See, the MRI is not at this point has not come as a kind of a marker to define treatment. The definition of treatment at this point is clinical and the type of injury, and then metabolic disorders, or for that matter, any kind of insult at this point, unless you are dealing with a neonatal epilepsy. The latest paper, which is a very powerful paper, I will say, which says that an early withdrawal is not going to change the outcome, both the seizure outcome and the developmental outcome. So even if you have a seizure later, you can start the treatment later. So that is the approach at this point. So earlier the better. At the time of discharge will be the best time before any kind of patient which is not having an active seizure or an active depressed sensorium at that point.
Okay, the last one for the day, sir. Vinyan sir, this is for you. One of the common causes of developmental epileptic encephalopathy is KCNQ2. So is it a good practice to start sodium channel blocker as the anti-seizure medication if clinically suspected, especially in periphery where the genetic testing and other facilities are not available? So if a child with DE comes, presuming it is more likely to be KCNQ2 rather than anything else, so what should be the what should be the therapeutic modality of choice?
See, it is again, it is we don't have real data here to clearly guide the therapy. See, which anti-epileptic drug to use depends on so many factors. See, as of now, the evidence says that phenobarbital, even the current RCTs have shown that phenobarbital is a better drug. But if you are thinking that this is a child who has got developmental epileptic encephalopathy, and as Professor Praveen Kumar was trying to say, that the patient doesn't have any antecedents, and the best thing is here the clear diagnosis, because a child who has got seizing without an antecedent history of any kind of perinatal insults, it can be a structural malformation also. So the structural malformation is a very common cause. So, but there also, we can say that a focal anti-epileptic drug will work. And there are some groups you use tegretol or oxcarbazepine in that age group. But the main problem with oxcarbazepine or a carbamazepine at that point is you don't have an IV preparation. So if you don't have an IV preparation and the patient is started on one oral drug, there is a chance that if the child goes into a kind of series of seizures, you may have to add another drug at that point. So the other option is you start phenytoin and as a first line drug. But again, the question here is, what is your diagnosis? So it is very difficult to clearly say that you are dealing with a KCNQ2 alone. It can be anything else also. So no hard and fast rules, I'll say.
Okay, I'll keep this the last now. This is an interesting one. What is the drug of choice for neonatal seizures in each of your centers, and do you change it? Do you vary it depending on the etiology?
Okay, I'll say, or sir, you
Either
want to say?
ways.
Yeah. See, I will say that maybe we have done a Delphi, so that is a part of the current paper which is coming out on management guidelines on neonatal seizures from ILAE. There was no consensus, I will say. okay, on etiology-driven practice in epilepsy, except that you are considering, as somebody has mentioned, when you are considering a genetic epilepsy of KCNQ2 or SCN2A, so then there is a role. Otherwise, at this point, that consensus across board was there is no clear evidence at this point. Practice, I think our center still follows the phenobarbital route, okay, and traditional practice, and involving probably levetiracetam is coming slowly into that, but not in a big way. Sir, PGI.
Praveen sir, your take on this.
So I think phenobarb stays the first line treatment across the units as of today. People have tried to do several trials of phenobarb versus other drugs, including levetiracetam. But if you look at the recent systematic reviews and meta-analysis, phenobarb somehow seems to be superior. A lot of concerns have been raised, but at the moment, I don't think we have a better drug as of now. Of course, in future, and I think one of the challenges that as I mentioned with the trials could be that they have not approached outcomes the way this particular paper describes, with Dr. Vinay being the co-author, because there's no continuous EEG being done. We don't look at seizure burden. It's basically the clinical seizure frequency, which is being looked at. Now, so as of today, I think in summary, phenobarb is the drug to be used, but yes, we look forward to more research on this.
I think we'll have to stop over here. We have overshot our time remarkably. Thank you so much, Vinyan sir, Praveen sir. Naveen sir, any last word?
No, thank you. It was a very interesting session, very informative for all of us. Thank you, sir. Thank you, Dr. Praveen.
Thank you.
Thank you. Thank you. Thank you,
sir. We'll stop over here. Thank you, everyone.
Thank you.
Thank you, sir.